one of the questions that came to my mind, you know, all of a sudden, opioids, big deal. I mean, I never heard so much about opioids in my life. When did it fall through the cracks? When did somebody finally discover that this is a big problem and we got to do something about it?
Well, I hate to be too negative, but I'll tell you what, in 2008, so nearly a decade ago, was when opiate overdose deaths eclipsed motor vehicle collision deaths for the United States. So we've known that this was coming for a long time.
And
I think it wasn't until it really hit home when we started to see more and more overdose deaths from powerful substances that were really rocking every community, not sparing anyone, not just an urban setting, but the suburban setting, the rural setting, when everyone started to kind of pick up their heads and look. And in Indiana specifically, our HIV outbreak of 2 years ago really brought people together around the idea that, okay, we have an HIV crisis, but it's the tip of the iceberg. And the things that underlie that iceberg are incredibly important. So we have to now build structures, infrastructure to take care of HIV and hepatitis C, but also substance use disorder, 3 chronic diseases together that would be so much, honestly, so much easier to treat if we just had one. And so we have to build systems to work around that. And then really the underlying components that brought all of that together, and I think powerful for many of us in the room that have been doing this for a long time, is that the driver of this particular epidemic is despair. And we fill the gaps of meaning and connectivity with opiates that have all of these unintended consequences beyond what you could ever imagine. And so it's harder to fight. But when you drive in and dig into how you connect people to hope for what's next, for the future, for their health, for their homes, for their lives, then we can not just get beyond this. Again, going back to not making this a fad. When, not if, when we are past opiates, will we have this same vigilance around methamphetamines and cocaine and other drugs of abuse? Will we make sure that we have this same vigilance when the individuals who are hurt by it don't look like everybody else or aren't in the majority? Can we make sure that health equity is our focus for the long term?
now, where does it start? You know, I heard Casey, the young lady, the mother that spoke, talked about how the doctor kept giving her Vicodin. Now, where does it really start to stop? You know, is it with the doctor? Is it
you talked about?
Dr. Warren, you want to talk about that?
Sure, and one of the things we know is that lots of folks get their opioids either through a prescription, so from a healthcare provider, or through family members or friends who have been prescribed. And so some of this is about changing the way we prescribe, and some of it's about changing our understanding of the impact of opioids. I think a lot of us were trained that for patients who had pain, you could treat them with opioids and they wouldn't become addicted. We now know that's not the case, and we now know that even short courses of opioids, even a few days post-op, can increase your risk of still being on that medication 3 months, 6 months later. So there really is an opportunity to change the prescribing practice, but I think there's also the opportunity to change our patient perception and demand. So in pediatrics, we see this a lot with fire drills, apparently. We see this a lot with antibiotics. So, you know, parents come in with a kid with a viral illness and they want an antibiotic, and we've done a lot of work on appropriate antibiotic prescribing and why that's not appropriate. The same is true with pain. Just because you come in with pain doesn't mean you need an opioid, and you need to think about those other modalities that could be used for therapy.
No, we don't need to think about it. The doctor needs to think about it.
Well, it works both ways. It's a demand issue, and we see this on lots of perinatal issues, actually. Early elective delivery is a great example. There's a provider part of the problem, but there's also a consumer part, and it takes both working together. It's not putting the blame solely on one, but it's saying we've all got to work together to make a difference in this.
Okay. Here's a question for you. Do we know what percentage of infant deaths are related to NAS or opioid exposure? Or what percentage of babies born with NAS die?
Yeah. So it's a great question. NAS in and of itself is not fatal, and lots of folks get really alarmed about that, but certainly the circumstances that led to the diagnosis of NAS may put that child at greater risk for abuse or neglect. Those social determinants that make life difficult, that probably resulted in the substance use to begin with, can make life difficult for that child in the first year of life. And so they may be at greater risk for those purposes, but the NAS in and of itself is not fatal. One of the things that we have looked at in particular in Tennessee is our sleep-related infant deaths, because that is such a large driver of infant mortality. And we thought that we were going to see lots of those cases involving parents who were intoxicated, and that's actually not been the case. By and large, it's babies who weren't sleeping alone on their back or in a crib. And so we, like you all, have focused on those ABCs.
Anybody want to join in, jump in, and say anything before we close it? Well, haven't they been great? Let's give them a big round of applause. Thank you so much.